So welcome everyone, and thank you for joining us this afternoon. This is a joint effort between Hillside Village and Home Healthcare, Hospice, and Community Services. So I appreciate being asked to come spend some time with you today and answer any questions you might have about hospice care. The title of our presentation is Hospice, It's Not What You Think. So we're hoping that we can answer many of your questions and clarify some myths and misunderstandings. So our teams on today's presentation, we do obviously have Joy, your marketing and outreach coordinator, and I believe Judy is on as well.
Our marketing director for Hillside Village and the Prospect Woodward.
Great.
Kim DePonde is actually here too, and she's our marketing coordinator. So she helps us actually keep our jobs going. And I'm not, yeah.
And Serene Sarna from Home Healthcare, Hospice, and Community Services. She's our philanthropy director, and unfortunately she had a conflict today, so she's not gonna be able to join us. So just want to talk about common myths and misunderstandings when it comes to hospice care. And let me just get this open a little bit better for me. Here we go. So a lot of people think when patients come on to hospice care, it's for the final days of life. And that death may be immediate when coming onto hospice care, but hospice is actually a 6-month benefit. So it's not meant to be used only in the last days of life. So unfortunately, that's tends to be when we get our referrals for patients for hospices in the final days. But it gives us a very limited amount of time to be able to work with those patients and those families to really help them to manage their pain, to work with them on just end of life and all of the things that we can do. We have chaplain services and psychosocial support through our social workers. And we really want to be able to spend that time with the family. So we want to make sure that people understand that it's truly a 6-month benefit. And that doesn't mean that after 6 months you have to come off service. If you're still with us after 6 months, you can remain on hospice services. So we have patients that have actually been on maybe a year or 2 years on hospice services. And it's just that they are choosing quality of life and palliation of symptoms versus curative treatment. And many people, when they hear the word hospice, think about morphine right off the bat. They think the hospice nurse is going to come in and she's going to start the morphine. So I just want to reassure people that we don't, morphine is a medication that is commonly used at end of life. We wouldn't come in right off the bat and start someone on that. It really is used to treat those end of life symptoms of pain and shortness of breath. And a lot of families worry about opioids. They worry that it's going to speed up the dying process. And we want to reassure people that the person receiving the morphine is declining because of the illness, with or without the morphine. And there's no evidence that the opioids actually hasten the dying process. In fact, some research suggests that using opioids to treat pain and shortness of breath near the end of life may help a person live longer. Because that pain and shortness of breath can be so exhausting. So it makes sense that treating these symptoms might slow down the rate of decline, if only for a few hours. If a person has never received morphine, we're not going to give them a high dose. We're going to give the initial dose is going to be low. And then we would increase it gradually as needed to maintain comfort. So I just want to reassure people, and that's a common myth that morphine hastens death. And we want to make sure that people have a good understanding of why we're using that particular medication at end of life, because it is so good at managing those symptoms of the pain and the shortness of breath. The other misunderstanding or myth is that if I go into hospice care, they're going to neglect me. They're not going to take care of me anymore. And that's absolutely not true. In fact, we're going to make sure that you're provided comfort, that you're enjoying quality of life. It does not mean neglect. It means a change to focus on comfort. So we may decide that we're not going to draw blood work or continue a particular treatment if it's distressing to you. But if you say you fall and you broke a bone, we'd still want you to go get that treated. If you got a pneumonia and needed antibiotics, we may still prescribe an antibiotic for that. So we are going to manage those symptoms, and we wouldn't allow someone to suffer. We're going to make sure that all of those things are managed to the best of our ability. So no, neglect is not something to fear when coming onto hospice services. So hospice care affirms life and focuses on improving the quality of life for persons and families facing a life-limiting illness. The primary goals of hospice care are to provide comfort, relieve physical, emotional, and spiritual suffering, and promote the dignity for terminally ill persons. Hospice care does not prolong nor hastens the dying process, and care is palliative, not curative. That means we're going to control pain and symptoms associated with the terminal illness, but our goal is not to cure it. Our focus is quality in the end of life. So if it's being able to be alert enough to spend a day visiting with your grandkids, or whatever it might mean for you for quality at end of life, we're going to make sure that happens for you. We make sure to educate and support family members and others who are involved in your care. We want to make sure they have a full understanding of what's going on and the process. So where is hospice provided? So hospice is a philosophy of care rather than a place. So some people, my mom's going on hospice, or when are you coming to pick her up? It's not a place. We provide hospice care wherever the person calls home. So that could be an actual home, an apartment. It could be an assisted living setting. It could be a nursing home. It could be a group home. Wherever that person calls home, we would provide hospice care. And the philosophy of hospice is really to recognize that quality of life, peace, and comfort at the end of life should be the focus of healthcare when curing the disease is no longer possible. So it was originally designed to be a non-institutional benefit, meaning that it was meant for patients residing at home. And then they opened it up to patients residing within facilities, realizing that hospice has something to offer to facilities with patients at end of life. We're there to support the facility staff just as we would the patient and the caregiver at home if the patient were at home. So we educate them as well. We want to make sure patients know their rights when they come onto hospice services. That's a big part of our initial visit when we come out to see a patient to initiate hospice services. We inform them of their rights verbally and in writing in the language of their preference. We do use language lines if that becomes so that language is not a barrier. And we always want to make sure people understand the hospice benefit. You can always revoke hospice services. I think that's one thing people may not understand is if they choose at another time, maybe they came on with cancer and they were told that there were no further treatments for them, and now a new trial has come up and their doctor feels they may be appropriate for it. They could revoke hospice services and go seek treatment for that. So it is something that you have the right to do, and you have the right to be informed of all your options. So you have the right to transfer to another hospice if you're not happy with the care provided by one hospice. And we provide all of this during that initial assessment, initial visit, where we go over the hospice benefit. We want to make sure people know of their rights. We are regulated by Medicare, so we have to follow those regulations, which includes patient rights. Hospice eligibility. So I want to just mention that anyone can request a hospice evaluation. So if you felt like there was a significant decline, or you're seeing your loved one, maybe they're not eating as much anymore, maybe they're sleeping more, maybe they're not getting involved as much in activity anymore, you can always call us. We can reach out to the physician on your behalf. We can always come out and do a hospice informational without a physician order. That's just going to provide you the information so that you have all that you need to make good choices. But for hospice to actually admit you, we do need a physician. Usually it's the attending physician in collaboration with our hospice medical director that determines that the patient has a prognosis of 6 months or less to live. They're no longer seeking curative treatment, and they meet clinical eligibility. And we'll get into that in just a minute. And we are required as a hospice agency regulated by Medicare to reassess eligibility at regular intervals. So there's a 90-day benefit period when you start, followed by another 90-day benefit period, followed by as many 60-day periods as you require to meet your needs. After the first 2 90-day benefit periods, our hospice medical director comes out to do what's called a face-to-face visit with you to see how things are going, how your symptoms are being managed, and to document any further decline to support that continued eligibility for the hospice benefit. So some examples of eligibility, weight loss. So we typically are looking at someone who's lost 10% or more of their body weight in a short period of time. But this could be, maybe you haven't gotten on the scale, so maybe you're having to buy smaller size clothing. Maybe the person's dentures no longer fit in their mouth because they've lost so much weight. Things like that are just as important to note as weight loss. Recurrent infections such as pneumonia and pyelonephritis. Pyelonephritis is a acute urinary tract infection. Things like that, recurrent, would make us think that there's something else going on there. Comorbid life-limiting illnesses such as late or end-stage CHF, that's congestive heart failure. That's a hospice-appropriate diagnosis. When someone gets so short of breath, it really inhibits their ability to participate in their activities of daily living. And other life-limiting illnesses such as end-stage dementia and chronic obstructive pulmonary disease, or COPD. We know in end-stage dementia, our loved ones can have difficulty just caring for themselves, and at some point they become unable to walk unassisted, unable to eat unassisted. That's usually when hospice is coming in, because they're starting to see the weight loss, they're starting to see the decline. End-stage renal disease is another one. Usually with end-stage renal disease, we would not admit to hospice services until the patient and the family were ready to discontinue dialysis. It can be a long and tedious process going out for dialysis appointments for many people. So when they've decided that they no longer want that, that would be the time to refer to hospice. Metastasized cares are always something that we would consider a hospice eligible diagnosis when cancer has started in one part of the body and moved to another area. Typically someone with a stage 4 lung cancer or a brain cancer is going to always be eligible for hospice, whether or not they've had metastasis to another site. And also patients with ALS and Parkinson's disease, we tend to see with these patients, they start to have dysphagia or difficulty swallowing and may aspirate or choke on their food and drink. And that tends to be a sign, along with some weight loss, that that patient may be ready for hospice services. So again, our hospice nurse would come out and assess for these things using our clinical guidelines to see if the patient met eligibility. Should relay this information to the hospice medical director along with the patient's physician to obtain certification of terminal illness.
And Michelle, before we jump, well,
Yeah.
If someone is living here at Hillside Village, or they've moved through the continuum of care and now they're in the Prospect Woodward, our team would help identify these things and help guide the resident and their loved ones through this to reach out to you.
Correct. Yes. So, what's nice about having, we have an excellent relationship with Hillside, and we have regular ongoing meetings on care collaboration. So we would be able to jump right in and assist with anything that you need. Yeah. So how is hospice reimbursed? Hospice is under the Medicare Part A benefit. So when you sign on to hospice services, we take over the Medicare Part A benefit. Which is typically what is used when you go for skilled treatment in a nursing facility or to a hospital. They bill Medicare Part A. So when you come on to hospice services, say you're on for your chronic obstructive pulmonary disease, you would no longer be going out seeking treatment for that diagnosis. We would be managing the symptoms at home, providing all of the medications and treatments necessary to manage that at home to avoid having to go to the hospital again. New Hampshire also has a hospice Medicaid benefit, so Medicaid provides hospice services as well. And also many commercial insurances and managed cares cover hospice. They see the benefit to having that, that oversight at the end of life. Many hospices, including us, are committed to caring for patients and will provide free care if necessary. So for patients who do not have funds and are not able to pay for care, we do provide the same level of service that we would for anyone with insurance. So that is not a barrier to care for anyone in our community. What's covered by the hospice benefit? So the hospice team and the following services related to the hospice diagnosis. So medical supplies, durable medical equipment, and medications that are necessary for the palliation of the pain and symptoms associated with the terminal illness. So we cover the cost of medical supplies like briefs, incontinence supplies, maybe barrier creams, things like that. Durable medical equipment like hospital beds, commodes, bedside tables, anything that you might need to maintain comfort at home, and definitely any type of medications that would be necessary to manage your symptoms. What's not covered? Nursing facility room and board is not covered under the hospice benefit. Care unrelated to the hospice diagnosis is not covered by the hospice benefit. So using the example of the patient with the chronic obstructive pulmonary disease, their lung disease, they can still go out and have treatment for their diabetes. They can still have their, go to the podiatrist to have their toenails cut. They can still go to get for hearing aids and all those type of things. Those would all still be covered. If these anything related to the diagnosis, though, we would want to go through the hospice team for collaboration. So we want to make sure that our patients aren't seeking care without consulting us first, because it may be a conflict. We want to make sure that we're doing things appropriately. Non-formulary medications and supplies are not covered. We usually are able to manage patients very well within our formulary. It's very rare that we have an instance that we have to go outside the formulary. When we do, we will, but we have a very vast formulary and are able to cover what is necessary and appropriate for palliation of symptoms. So people will ask us about vitamins and supplements, things like that. Those things are not covered under hospice services. Those are not palliative in nature, and that's not something covered by the Medicare hospice benefit. Curative or aggressive treatments, as we said, if you're going to go seek maybe radiation for your lung cancer, that would not be covered under the hospice benefit. Now, if you had a need, maybe you had a tumor that was causing some discomfort, we have on some instances done palliative radiation to manage pain or symptoms, but this is not curative in nature. This is to manage the pain and the symptom to make it more bearable. There's 4 levels of hospice care. So routine care is the most common level of hospice care, and that's what most of our patients are under. That's primarily for any individual that's elected to receive hospice care at their residence. It's under routine level of care. Hospice gets reimbursed on a daily rate, a per diem rate for that, and we provide all the care and services necessary to meet that patient's needs. Under inpatient respite care, this is a benefit for your loved ones, so for the caregiver. So if a patient's residing at home and maybe the daughter is caring for mom and she's been there for weeks and she needs a break, we are able to provide a 5-day respite stay at one of our facilities, either one of our nursing homes or in the hospital setting, for a 5-day respite to give that caregiver a break. We also have general inpatient level of care, and this is for acute pain and symptom management. And this is where we're not able to manage it in any other way at home. So we really need to get you into a facility and manage the pain or whatever symptoms, maybe it's agitation, anxiety that are uncontrolled, and get them to a manageable level. And that's where hospice is, that's the one and only time where hospice is actually covering that hospital stay or that stay in that nursing facility. I misspoke. Under respite, we're covering the 5 days. Under general inpatient, we're covering it for the acute symptom management. So 2 times. Under respite, you get a 5-day stay for respite for the caregiver. And under general inpatient, it's for pain and symptom management. It's usually short term. We're usually able to get those symptoms controlled fairly quickly. And then you would go back to routine level of care after that. Similarly, if you didn't want to leave your home and we were needing to manage those symptoms in the home and maybe bring in a pain pump, or in some instances, we've had to do palliative sedation in the home setting, then we can utilize what's called continuous care. And that's where the nurse is actually going to stay until that pain or symptom is managed, and educate the family member or caregiver how to continue to maintain that comfort level. So that's again for during a crisis, during acute pain or symptom management, that then it's called continuous care, and the nurse would actually have to be there continuously monitoring those symptoms, documenting hourly what's going on until those symptoms were resolved. Hospice is provided by an interdisciplinary team that works with the team there at Hillside. It includes primarily the patient and or family and caregiver. That's the center of our team, along with the facility staff and our hospice team being the primary care provider. So the patient's physician, our hospice medical director. We also have a hospice physician that works with her, and our hospice nurse, the social worker, our spiritual care counselors, our licensed nursing assistants that provide assistance with personal care needs, and our volunteers who can provide just companionship. They can do, they can come and read to patients. Right now, we have a lot of them writing letters and calling due to concerns of COVID and some people not wanting visits. They're making calls and just staying in contact with our patients so that they have that connection. Our bereavement counselor is part of our team, along with a dietitian who's available. And if patients do need physical or occupational therapy, maybe it's for concerns of safe transfer in the home. Maybe they've had frequent falls and we need to teach them how to transfer safely at home. We can call in physical therapy or occupational therapy and have that education provided and have some brief treatment from therapy. So our goal with therapy is not to bring them back to a prior state of health. It really is to help manage that ongoing deterioration to keep them safe at home. And we always have our pharmacists available. It's a very important part of our team. They review all of our patients' medications upon admission and anytime we add any new medications, and they advise us on any necessary, anything that we need to be aware of as far as potential side effects, anything like that. So our hospice team is available 24 hours a day. And I want to clarify for everyone that when hospice comes in, there does need to be a primary caregiver in the home, someone that's going to be helping that patient 24 hours a day. Hospice is going to supplement that care. And we're going to have our aide come in, we're going to have our nurse come in, the chaplain, the social worker, and we're going to supplement the care, and we're going to teach the caregivers how to best care for their loved one at home. But 24 hours a day, we are available. We have our triage staff and we have our on-call nurses. And so we want people to call when they're having pain, anxiety, nausea and vomiting, constipation, agitation, shortness of breath, or depression. A lot of the pain medications we use can cause constipation. So we want to make sure that, you know, we're taking care of that. It's a very common side effect. And our team understands that pain is not always just physical. It can be spiritual, it can be emotional, and we address this. So we do have spiritual counseling, as I mentioned, bereavement counseling, relaxation therapy, massage therapy. We have massage therapy provided by Mary Beth Given. Mary Beth has done some wonderful work with our patients. She's done some reflexology with our patient, with a particular patient I'm thinking of who was having uncontrolled nausea and vomiting. She did some reflexology with that patient, was able to manage it where we weren't able with all the medications we had tried. We also have nurses and volunteers who can do Reiki, music therapy, aromatherapy. It's all, you know, patient driven. So it would need to be something that the patient was willing to participate in. So symptom management at end of life is very important. That's probably the biggest thing that we do. And one of the benefits of being on hospice care is we are typically able to utilize higher doses and more frequently than those you routinely used in the skilled nursing facility, because we need to get optimal pain and symptom control. And again, we start gradually and we increase as needed to meet the need. We may need to use medications sublingually or under the tongue, transdermally like a patch, subcutaneously, which is an infusion, kind of like an IV, but it's just under the skin, under the subcutaneous tissue. We sometimes use creams or gels for pain or symptom management. Obviously your tablets and your liquids that you're used to, and sometimes suppositories for pain or symptom relief. So we have many options to manage pain and other things that may come up at end of life. We want people to call when they notice any significant change in condition or in the symptoms requiring a change in the plan of care. We want them to call when the current interventions are not effective, or they're having increased pain, anxiety, nausea, or vomiting. When you're requiring more frequent PRN, that means as needed medication. So we might have you on scheduled medication twice a day, but you're having to take your breakthrough medication more and more frequently. That means we need to adjust your plan of care for your pain medications and get you on a better regimen. If you're having shortness of breath, we want you to call us. Agitation, restlessness, falls. A lot of our patients will have increased falls towards end of life. Definitely want you to call us before seeking hospitalization when you're on hospice care, because again, we took over that Medicare Part A benefit, which would be your hospital benefit. So we would need to be aware of any care you were seeking at the hospital and coordinate that. And at any time there's any questions or concerns, and that's not just for the patient, that's for the family, for the caregiver, for the physician. If there's any questions or concerns, we want them to be calling and asking us. That's one thing that I can't say enough is we're here to provide information and share with all of you. So feel free to reach out at any time if you just have a question about hospice. So for comfort measures in the final days, one of the most important things that we say is we want to promote a quiet, private environment for residents and families that supports the intimate process of dying. We want to support personal rituals, different cultural rituals for that person, and provide emotional, spiritual, and bereavement care. We'll offer we'll offer food and fluids only as the dying person desires and can take. We'll reposition them frequently to ensure comfort, offer frequent oral care. We may use artificial tears or eye lubricant for increased comfort, moisten their mouth for comfort. We might limit taking vital signs as it may be uncomfortable. We might stop medications that are no longer essential. Maybe it's those vitamins, you know. Sometimes we've noticed when we come in and we discontinue a lot of these medications that people have been on for years, you know, they've been on their vitamin Ds and their Lipitors and all these other things, and they've stopped eating. They're filling their bellies with all these pills. Sometimes they may do better when we discontinue some of these medications. We may stop drawing blood. We may stop doing blood work or finger sticks for blood sugars if it's appropriate. And we might remove any non-essential equipment in the room that might distract the caregiver. We want this to really be an intimate time for the patient and the family. Deserves as much respect as birth. So physical signs that indicate the end of life. We tend to see our patients are sleeping more. They may have coolness in their arms and legs, skin color changes. They may become incontinent of bowel and bladder or have decreased urinary output. They may have a decreased appetite or thirst. They may want little or no food or fluid. They may have changes in their breathing patterns, congestion, gurgling sounds with respirations. And these are all things that we can help them with. When patients are imminent, they will show signs that we were just talking about, that discoloration, change in a level of alertness. And so we want you to call the hospice team when you're seeing any of those signs that we talked about so we can be there to support that patient. And when the patient dies, we want you to call a team because we want to be there again to support the patient, the family, and in a facility, the facility staff. They've been caring for that person. Here at excuse me, you got me doing it now. Home Healthcare, Hospice, and Community Services. We are part of the We Honor Veterans program. And it's very important to us to make sure that we're honoring and recognizing our veterans that we care for. We provide pinning ceremonies and certificates for those patients who served in the military. And we want to make sure that we recognize them for their service, especially at end of life. So we do individual pinning ceremonies throughout the year and can do group pinning ceremonies on Veterans Day and other special holidays. But the individual pinning ceremonies tend to be very emotional and very rewarding for the entire team to witness. Bereavement is part of the hospice benefit, and it's offered for 13 months to the family. That would include phone calls, short-term one-on-one bereavement counseling, support groups, educational forums, written information on processing grief, like newsletters, and also memorial services. So HCS offers 2 a year of the memorial service. In the spring, we do a butterfly release. And around wintertime, we also do another remembrance ceremony. And that's something that we invite all of our bereaved family members to attend. Marguerite Cheney is our bereavement counselor. She's been with us for quite a long time. She runs several groups. She's running one right now, which is Grief and the Holidays during COVID, that you're all welcome to attend. It's open to the community. So in summary, the hospice is a holistic approach. It's for the whole person and their loved ones. We treat the whole person and not just the disease. We focus on the needs of both the patient and the family. The care is provided by an interdisciplinary team of experts. We address pain and symptom management, emotional, psychosocial, and spiritual needs, and we help with funeral and planning and arrangements, and then bereavement for the family and the caregiver after the patient's death. We work very closely with Hillside Village Keene, and here are your contacts. I believe Judy and Joy are both on the call today, and here's their contact information. And this is our home healthcare, hospice, and community services 24-hour hospice hotline, so you can call that at any time. There's also our main number and our fax number. Feel free to call me directly. My number's on there. That'll be going out with the recorded program, so if you have any questions, please feel free to reach out. But at this point, I am going to open it up to all of you and see if you have any questions. I'm going to stop the screen share now.
We should all pop back up. Just remember that you're muted, so you should be able to unmute yourself if you're interested in doing that. And do we have any questions? No questions, huh? Wow, Michelle, you did a wonderful job.
A lot of information. It's a lot of information.
You did a wonderful job.
Thank you. If you think of questions after, feel free to reach out, like I said. But
yeah, I know, Jenna, I saw an email pop up that you're interested in maybe talking to Michelle about getting the presentation to share with your coworkers. So I'm going to let you, Michelle, do that. I can forward along the information.
yes, definitely.
Oh, Judy has a question.
I think Mary had a question.
Just a couple of comments. Thank you so much. Hospice, I'm very glad to be alive in a hospice availability time of this world, because there was a time when we didn't have it, and we're very lucky, I think. My sister died with hospice, and I just remember the nurse as she left said, this kind of getting back to your same respect as birth comment.
Yeah,
That's great.
And
Yeah.
what she said was, I consider myself a midwife for the other side. And that helped my brother-in-law so much. It just, it just shifts, a little paradigm shift. It was just wonderful. So I never forgot that. And thank you for the work you do.
Thank you, Mary. Thank you. There's actually a book out there. It's written by a hospice nurse, Midwife to the Soul. Yeah, it is. It's just as important. You're coming into this world or going out of this world, and it's that special and intimate, and to be part of that is priceless.
Yeah. It really does make a difference in people's lives. I'm sure everyone has a story maybe too with what hospice meant to them. And I had dealt with hospice in the private home and in a nursing home with each parent. And in both instances, it was just such a comfort to have. And it really did make end of life much easier, not only for my dad and my mom, but for us as a family.
Mm-hmm.
We talked about being home before we started, and we didn't even realize that those shifts continue after hospice comes in and helps, but it really is up to the family to provide the majority of care. So it's it's important to know that when you're making choices, all of you, when you're talking to your families, and how do you want that handled as you go forward.
Right. And we love to help with those conversations too. So those can be tough conversations. Our culture does not like to talk about end of life.
No.
So we can help with that as well. And just having you all on this call, listening to the information, being able to share it with your friends and loved ones, it's helping to spread the word about hospice and make sure people receive the services they need.
Yeah.
So I thank you for all attending today.
Thank you, Michelle.
All right, well, thank you. Thank you so much, Michelle. This has been great, both of these sessions, and to all of you who have joined us today. And, thank you again. And we'll make sure that if you would like any of the contact information, feel free to reach out to me through email, and I can get that for you, or whatever you need, we can definitely make sure you get it. So with that.
I did have a question after all. What are language lines? You said you use language lines.
So it's an interpreter line. So when our nurse is out there, she can actually call on her cell phone and dial into someone that will interpret for her to the family. So if someone is Spanish speaking, or we've had Polish, we've had French, we've had German, we want to make sure they understand everything that we're saying very clearly. And sometimes if we use the family member who also speaks it to interpret, it may not be the patient's wishes we're getting, it may be that family member's wishes. So we like to use it's our policy to use the interpreter line to make sure that we're getting truly what the patient's saying.
Yeah, that is very important.
Yeah.
I know that I'll form it into a question, but each person if I understand or remember, is assigned sort of a caseworker to the situation. And one of the things, and you can expand on it, is the guidance that we got. Doctors tend to speak in doctor speak, and sometimes you're just kind of looking at them going, I don't know what that means, whatever you think. So Michelle, how do you feel about what that would add on to?
I think it's true. We tend to interpret a lot. A lot of times when we come out, the doctor's only told the patient that you could use some help. Why don't you call hospice?
Okay.
So we do a lot of education. We try to educate physicians and nurse practitioners as well about hospice services, just to make sure they're aware of what's out there and available. But there is room for interpretation, sure, for what the physician has said. Some are very, very good, and some are very skilled at having those conversations, and others need a little help.
Tina, you have a question?
Yeah, just curious, how many men work with hospice? How many males? Yeah.
So I have one male nurse, and then I have two male spiritual counselors or chaplains. Yep, and I'm trying to think. I think that's it. Just the three of them. Yep, it tends to be more women. Tends to be. When we've had male aides in the past, it tends to be the females refuse the male aides. So we tend to have more female aides than we do the male aides. But I can say our male nurses just as empathetic and compassionate as our female nurses are, and just as skilled.
Yeah, there's a wonderful gentleman that comes here to Prospect Woodward. So I've met him a few times, and I know he's a registered nurse and care coordinator. So
yes. So our RNs do, when a patient comes on to hospice, that family and the patient get a hospice RN case manager that oversees all of that care, including coordinating with the other disciplines, coordinating with the facilities and the families.
Yep. All right. Well, if again, and if more questions come up, we're easily, can be reached, and I can get you Michelle's direct information too. So, you certainly don't have to go through me to get any questions answered. I'm going to thank all of you. A special thanks to Michelle too. Thank you so much for sharing this. Yeah, I think it was great.
Welcome. Glad to thanks, Michelle. Thank you.
And I wish everyone a wonderful holiday next week, no matter how it looks for you. And I just wish you all well, and thank you for participating.
Thank you.
Everyone. Happy Thanksgiving.
You too.
Bye-bye.